Hi, everyone. I'm Kristan Hawkins. Welcome to this new episode of the Explicitly Pro-Life podcast. As you all know, we are in the season 3 of having difficult conversations. And I wanted to bring on a friend that I met years ago in the pro-life movement, a physician in Charleston, West Virginia, Dr. Byron Calhoun, who's agreed to come on today to talk about the hard cases, poor prenatal diagnoses, cases where we have high-risk pregnancies, because it's common justification that we hear for why we need abortion to be legal in all 9 months of pregnancy for whatever reason and taxpayer funded is because of these extreme and extraordinary cases that sometimes do present themselves. So Dr. Calhoun is a professor. He's a vice chair of obstetrics and gynecology at the College of Medicine at WVU University, so West Virginia University in Charleston. He is a diplomat at the American Board of Obstetrics and Gynecology with board certification in general OB and gynecology and a subspecialty of maternal fetal medicine. He is also board certified in addictions medicine. He's a member of the American College of OBGYNs and Society of Maternal Fetal Medicine. Dr. Calhoun received his bachelor's in science in 1979 as a distinguished graduate of the United States Air Force Academy. He graduated from the University of Iowa Medical School with an MD in 1983, completed his residency in OBGYN at the University of Missouri at Columbia in 1987, and finished his fellowship in maternal fetal medicine at Oregon Health Sciences University in 1989. He's authored more than 90 peer-reviewed articles in OBGYN literature, presented over 100 scientific papers, participated in over 40 research projects, and published numerous articles on medical aspects of OBGYN. He edited and published a monograph dealing with addictions and women's health entitled Tobacco Cessation, Substance Abuse Treatment, and Women's Health Care with Springer Publications. And if you're ever looking for great research to talk about abortion and the effects of abortion on women, high-risk pregnancies, I guarantee you when you're searching for, if you're at PubMed, searching for academic papers, you will come across Dr. Calhoun and his work. So thank you, Dr. Calhoun, for coming on today.
My pleasure. Glad to be here.
Well, in case you haven't noticed, I cannot pronounce obstetrics very well, so I always shorten it to OBGYN. Despite the fact that I do this for a living, I have a problem getting words out of my mouth sometimes, so I'm sorry for that. But I want to thank you for coming on because you and I have had conversations over the years. I know you've graciously gone and spoken in front of med school audiences for our Med Students for Life groups and our fellowships. So when we had those at Students for Life, and your expertise is exactly what we need in the pro-life movement. In fact, we need to hear more from you and other physicians who serve in this field. So I'm going to just ask you the hard questions today, and I hope you're okay with that. Because I want to ask the questions I think a lot of people who talk about abortion, who advocate against the violence of abortion, commonly hear. So first and foremost, are there cases that necessitate an abortion?
Well, I always want to sort of define that because there are cases where the mother's life might be at risk and you would need to deliver the baby prematurely and the baby would die from prematurity, such as sepsis or severe high blood pressure preeclampsia. However, what I always want to clarify, you don't have to take the life of the baby to save the life of the mother. So yes, there are cases in which you would have to do an early delivery or, if you will, an abortion below 20 weeks gestation, which is what an abortion is medically, to save the mother. But you don't have to do abortions in general because most of the time when these happen, the babies are survivable or they're 23 or 24 weeks and can be resuscitated. So it really is very, very, very rare. And you don't have to take the life of the baby to do this. So it's really very rare. So it's an exception. And again, you don't have to take the life of the baby to save the mother's life. So my response is always, no, you really don't need to do a feticidal act to save the life of the mother.
That's right. You don't have to go in and intentionally end the life of the human being. And I think what's so great about all of the advancements that we've seen in science is were actually able to care for these children at a younger and younger age, where, even in my lifetime, the chances of survivability has dramatically increased for these children who are born severely premature because their mothers had to have been induced. Or what are for right now, with where medical science is and technology is, what's the survivability rates of a child who may be born alive at 22 weeks or 23 weeks?
Well, part of it, generally at 22 weeks, we think there's really no survivability. The lungs aren't developed enough in general. Depending where you're at, if you're at a very good center, we have a good center here. At 23 weeks, I think our survivability here, and I may be a little bit off, is about 30%, maybe to 40% survival at 23. By 25 or 26, it's up about 70+%, and most of those children are going to do actually quite well. And what's really interesting is by the time you get 28 weeks, it's 93 to 95% survival, and 93 to 95% of those children are actually going to be intact and do just fine. Actually, they'll be in the hospital for a while. They do very, very well. So again, weeks are important, but we are now resuscitating babies here at 23 weeks and treating them aggressively and giving them steroids and treating them very, very aggressively. So like you said, a few years ago, no one was talking about 23 weeks for resuscitation.
So, and is that so? When you're talking about these children who are born premature, whether their mothers were induced, they had to deliver because of sepsis or something like that, is the main concern with these children is their lung development?
Right. You have to have the development of the terminal bronchioles, the part of your air sacs that breathe. So unfortunately, really before 22 to 23 weeks, those are not physiologically developed. It's just part of embryology. They're not developed. So there's no way to give, to ventilate those children who don't have that. So it's a limitation of the physiology that we see. Now, someday they may be able to do something with some sort of artificial womb or some sort of a liquefied some sort of resuscitative fluid. Who knows? But that right now, that's our limitation, is being able to ventilate these children. Yes.
The artificial womb, that's an interesting talking point, because I know in the UK, I don't know if you're up on any of the technology on that. I've read a couple of things about the artificial womb development. It's not really being developed to save lives. It's the way they were discussing it was there could be three parents, and they would do some interesting things, and then you wouldn't have to pay surrogates if this isn't a same-sex couple, and it would take away that challenge of surrogacy. But it's an interesting argument, if and when these artificial wombs can be developed. Because that would really take away the arguments that the abortion left uses for the justification for abortion, if there was a way to transplant a child into an artificial womb safely. So that's another topic, but it's something that's emerging, and I've seen noticeable increase in conversations about. So I want to talk about poor prenatal diagnosis. This is something that I think all of us in the pro-life movement, and even if you're not in the pro-life movement, I'm sure you know of someone, a family who received a prenatal diagnosis, someone being told that their child had Down syndrome, trisomy 18, trisomy 13, SFLA, that their child wouldn't survive outside of the womb. I guess, can you give me some of the examples, or what are the most common adverse prenatal diagnosis that we see, where women are told, you should just have the abortion, and what's an alternative for her?
Right. Well, I think part of it has become the whole societal idea, basically, of looking at eugenics, and that we're somehow going to create these perfect children, this perfect race. And if you look at places like Iceland, that's 100% of their Downs babies are aborted. In the world, it's probably about 80 to 90%. In the United States, it's slightly less than that, maybe not quite 90, maybe 85%. But what's really interesting is, of course, Down syndrome is not a lethal anomaly in the sense that you would die shortly after birth. And as you were pointing out earlier about trisomy 13 and 18, the average life expectancy in some of the later literature now in the last few years now, the survival rates to 5 years is about 40%.
Hmm.
for trisomy 13 and 18 now. And in fact, those survivabilities of the trisomy 13 and 18 almost mirror what we talked about, the survivability of the 22, 23-week babies, right, that have survived from the neonatal period to 5 years. So there's very little difference really between the extremely premature babies and the trisomies. And the anencephalics, of course, those babies generally die within the first few hours to few days of life. There's a few that live longer if they have the skin over the head. So it's not truly, there's not a membrane, but actual skin over the head. And those babies sometimes will live for a year or two. So the adverse diagnoses that are the most severe really are the babies with anencephaly, and then probably the babies with the trisomy 13s and 18s, or the children who have multiple anomalies that have a chromosomal abnormality, complex heart defects, who are very, very sick, and really their survivability is very limited because of the severity of the structural anomalies along with their trisomic syndrome. So that's really what you see. And then there's babies who don't have kidneys, who don't develop lungs, renal agenesis it's called. So those babies can't be resuscitated. They don't develop their lungs either. There's no fluid. So those are the ones we see that probably the most commonly are the babies with no kidneys, the anencephaly babies, the trisomy 13s and 18s, and then the 21s who are not a lethal anomaly, but are somehow eugenically seen as unfit for life. It's very interesting to me because if you've ever been in a family or seen a family who has a baby with trisomy 21, or a child or an adult with trisomy 21, they're just amazing individuals, very, very loving, very interactive, very social, most of them, and they're just wonderful, wonderful people. So for me, it's always find it very interesting to get into the eugenic argument because every life to me is worth living.
Absolutely. And for those who don't know, trisomy 21 is Down syndrome.
Right.
So I guess, are there cases when a mother is pregnant with a child who has trisomy 18 or a child with anencephaly? Is it medically necessary for her to have an abortion? What would an abortion do?
Well, that's a very good question. And of course, I always, since I'm a big proponent of hospice, which I'm sure we'll talk about a little bit later, that the whole idea is that most of these pregnancies are not endangering the life of the mother. There's no medical reason to abort them or deliver them prematurely or do anything out of the ordinary obstetrical care. They keep saying that they're going to somehow make it better. There's been some very good literature out of the world literature, particularly from places like Denmark and other countries who have actually pretty good records, looking at terminations of pregnancies and looking at outcomes and showing that these women who terminate pregnancies for anomalies actually do very, very much worse than those who don't do that. And there's a very high incidence of significant post-traumatic stress, of anxiety, of depression, of really significant psychological damage done by abortions and the loss of a wanted child. There was also another very interesting study that was done on anencephalics, looking at those patients who, women who terminated their pregnancies and those who did not, and found an increased incidence of depression and anxiety and coping skills that were much less robust in the patients who had terminated their anencephalics versus those who did more of the hospice and comfort care for their babies. So there's actually data support it's not better for you to terminate a pregnancy for anomalies in particular.
It's interesting you talk about the data being good coming out of Denmark, because I often find when I'm preparing for a speech for a campus or something like that, I often go to the Danish or Finnish research because we don't have a national abortion reporting law in this country. Do you find that you have to kind of go and look overseas to countries where abortion is legal and it's mainstream, and that their government, whether it's socialized medicine or whatever, is collecting all that data? I know it's a kind of a side point, but I find it interesting.
It is very interesting. A lot of times when I'm trying to do papers or research, I have to go to find linkage data, like you said, in countries like Finland or Denmark, sometimes in the German states, Sweden. Holland has actually quite good data too. The Netherlands have quite good linked data, and they've had data back since 1969 or 70, and they have most of the data links not just to surgeries and visits, they also have all the outpatient as well, a lot of that in their medications. So we can actually look at mental health by looking at medications. We can look at outpatient mental health visits. So some very interesting things that can come from that. And as you pointed out, we really do not have any data on abortion in particular, and even on any of the complications, really of pregnancy. A lot of it, even the mortality rates are terrible here because there's not mandatory reporting, and the data is not collected in a uniform manner, and states aren't even required to report some of this data. So it's really a bit of a mishmash of data that you see.
Mm-hmm. Yeah, I often find that interesting is that, those who advocate for abortion always, try to accuse us of being anti-science and we don't have the facts. And I'm the one sitting there trying to get all of this data, and that you can't actually get the data in the United States. And you're having to you're right, you have to put together data coming from different places. So you mentioned perinatal hospice. Can you explain that to folks, what that is and why that was developed?
Well, originally it was a sort of a brainchild of 2 or 3 physicians and myself, really Rick Hume, an old colleague of mine, and Nathan Holke, when I was long ago back in my military days in Madigan Army Medical Center, when we did not have the ability in the military to do abortions. And so we were trying to figure out what could we offer people. And we realized there wasn't really a program for people with an adverse prenatal diagnosis. So what we said was, well, why don't we offer end-of-life care to the babies, families before the babies are born, and we can develop a pathway for pathway for grief and for anticipatory grieving and for how to take care of these babies who are going to have a shortened life, like the encephalic we talked about, shortened life, and how to do that in a very compassionate and more structured and more basically life-affirming way, and to give these families the support they needed to do this, to have this journey, if you will, through the. And I call perinatal hospice basically is just transferring the end-of-life care that has been developed by Cecily Saunders back in the 60s to the baby or the fetus before it's born, so that we can do the end-of-life care for the baby with the family itself.
Where can, I guess, if you've never heard about perinatal hospice, where can folks go? So if they have a friend or a loved one who's facing a situation, they're being told your child is going to die immediately after birth, or your child has SFLA, where can they go to get, I guess, hooked up with a doctor, a physician, or in their community who will walk with them through this?
Well, the best, Amy Kubelbeck has a very good website. It's called Perinatal Hospice, all one word, perinatal, PERNITAL, perinatalhospice.org. And it has lists. There's over 300 hospice now in the perinatal hospice in the United States, and I think over 70 internationally now. So that has the best list, but it also has providers in there. It has blogs. It has support groups. It has literature. I mean, it's a treasure trove of information. So if you go to perinatalhospice.org, that's probably the best source of the information. You could also go, there are pro-life maternal fetal medicine, some listed in the APLOG website, the pro-life OBGYN website. And that may be another option as well, because that has the pro-life physicians in areas that would be useful, and obstetricians as well that would help provide that care. So those would be the resources that I would suggest.
Now, I guess walk me through, I think those are great resources. We need to keep that in mind, perinatalhospice.org, and then also the APLOG website, the American Association of Pro-Life OBGYNs. And it's great if you need a gynecologist and you're not pregnant. They have a great list, and it's a national database, and I use it myself. But I guess, can you walk me through, so a child has been diagnosed with anencephaly in the womb. As a physician, what goes on there, the conversations with the parents, if the parents say, no, we're not going to, quote unquote, terminate this pregnancy, we're going to deliver our child. What are the steps that have to be taken there, and what has to be prepared for leading up to the delivery of the child, and then ready to care for the child immediately after birth?
Well, I think that those are very good questions, and this is why it's important. I think to when you deal with patients and you have the opportunity with these different groups that have established perinatal care, there are actually perinatal guidelines that have developed by the neonatal and perinatal hospice organizations in the country. But the bottom line is you have to have a physician who's willing to provide that care and to walk alongside the patients. Once the diagnosis is established, generally what we do is we meet with the patients and we establish, just like we would anyone else, their obstetrical care, which usually is frequent ultrasounds to ensure that the baby's still alive, that we're still dealing with a pregnancy that's progressing. We do the normal pregnancy visits because we need to watch for any obstetrical complications. We also have I have basically a birthing plan and a whole series of questions that I put together for the patients and their family so that they can answer the questions about what they want to do for fetal monitoring. What do they want to do for delivery? If this baby shows signs of distress, do they want a live birth, or are they just wanting to have a vaginal delivery and not worry about a C-section? Do they want a C-section so they have a live birth so they can baptize their baby, or they can have their baby born alive? Those are important questions. Do they want what sort of comfort measures do they want? Do they want to try to feed the baby? Do they want to try to do oxygen for comfort? Are they talking about any of the medications they might want to use? And this is where I bring in the neonatologists and have them talk with the families. We try to get the nurses. We have nurses who's basically are very skilled in our labor and delivery with these patients, and we get them involved to help us do all the things we need to do. We have photography involved for the babies. Now I lay me down to sleep is very good, but we actually have photographers here as well. Do they want mementos? How do they want to do that? All the things that are involved with that, handprints. And we also make exceptions sometimes with regard to who can come for the deliveries. We let certain siblings in. Some places don't like to have children below a certain age. COVID's made this really crazy, but sometimes we can bring other people in, or we can do video. There's other ways of doing these things. So that's how we very much up front make sure we have the delivery plan, make sure we have all the things in place for this family to try to give them as much comfort and as much of the care and the whole holding close, if you will, of this whole process for them, to give them the time with their baby, which will be limited, but give them a maximum amount of impact in that time they're able to spend with the baby.
That's beautiful to see that it's like a holistic plan and approach that you all have. It's not just the clinical side, but it's also what can we do with the family, and to make the family a part of this and give the family as much time as possible with their child. It's great. Many people don't know this, but my first sister actually died shortly after childbirth, and it was in 1989. So my parents had no idea, going into the delivery of my sister Kelly Jo, that she would die shortly after birth, and even then, it wasn't, her body, her remains were not tested for genetic. So even when I got pregnant with my first child, I wondered, is there something genetically that we should be concerned about? And, little did I know that I was a carrier for CF, as well as my husband. My son being born with cystic fibrosis, but I thought about Kelly Jo and her birth, and it almost sounds like reading, the death certificate, that she probably had trisomy 13, just from what I know of learning about trisomy 13, trisomy 18. But it's very hard because back then there wasn't any testing. It was just genetic abnormality. And so I think about the pain that my mother went through, and just wishing she had that sort of support going into the birth of my sister, because I think it would have made the healing process, it would have been a very painful pregnancy to think about, my sister and her daughter as having this illness where, and this genetic abnormality that she probably won't survive, but to know that she would be able to have that time and to be surprised, I think that's why it's so important. Today we talk about prenatal diagnosis. And I think, it's a good thing that we're doing ultrasounds at 20 weeks and scanning. I guess that leads me to kind of my next question. Somebody who does this for a living, are you concerned about the advances they're making in prenatal diagnosis? I know when I was pregnant with Gunnar, I refused all prenatal testing. Obviously, I did the 20-week ultrasound where they, use the ultrasound to look at the chambers of the heart. But I refused the amniocentesis. But then every other child I had, I remember I went to a pro-life OBGYN for Maverick and Gracie. For Bear, I went to a pro-life OBGYN, but he wasn't in a pro-life practice. And I had to see all the other OBs in the practice during the course of my pregnancy. And every single appointment, I had to reject an amniocentesis and a CVS test. And they knew that I had one child with cystic fibrosis. Are you concerned about the advances that they're making, or do you think that it's helpful in prenatal diagnoses?
Well, I think that the technologies can be used for good or for ill, and the way in which they're administered is really the issue. And part of the problem I really have with a lot of the advanced prenatal diagnosis is that we will now send blood off and you're testing for, say, several hundred things, or 100 things, or 50 things, and what you're not doing is not putting it under a protocol to say, okay, if I find these positive things, what are we going to do with it? Or are we going to study these things now so we know what the outcomes are, and we're able to actually now say, okay, we now have a child who may have, say, spinal muscular atrophy, SMA, or cystic fibrosis. We could use your example. If we decide we have a baby who might be at risk or does have cystic fibrosis, can we treat that in utero? Is this part of what our protocol is, so we can leverage the technology to help us say, is there something we can do to make this better, and or perhaps be better prepared for treatment after we deliver? And I find that to be the most reasonable way. Unfortunately, as you pointed out, it's become the hobby horse of trying to, again, have this eugenics sort of utopia where we're all going to have great genes, which none of us do. We all have something, right, that's not really, because of our humanity, we have something that's not going to be good, right? It's going to be effective, whatever that word means. So that's the issue. So I don't like to give people tests that I don't know what I or they are going to do with it. I had a couple here not too long ago, cystic fibrosis in another child. One of the rare ones. I don't know exactly the deletion. Dad didn't know. Mom had the classic Delta 508, right? So they came in and said their doctor said they should do an amnio. And I looked at him and I said, well, but why do you want to do an amnio? They said, well, our doctor said so. And I said, but what are you going to do with it if you do it? Are you going to terminate your pregnancy? Well, no. We already have a child with cystic fibrosis. We don't want to do that. I said, so why do you want to do that? You're just putting your pregnancy at risk for loss. Not high, but loss by doing this procedure for something you're not going to do, and it's not a lethal anomaly, and you're not going to do anything about it anyway. But that's the mindset of this eugenically driven group of people that, above all, have to just, again, over and over and over again, dog people for getting a diagnosis, instead of saying one time to this couple, would you like to? Okay, then we're done. We're fine. We just make a note of that, and we don't ever ask you again, because it's none of my business to keep after you and hounding you when you've made a decision. Do
you think that you get hounded like this because of, or the patients, I guess, get hounded because of the wrongful birth lawsuits that are happening? Because a couple years ago in New York City, a woman who wrote for New York Times, their magazine, The Cut, actually wrote an article. And it was about her son, Dudley. Her son, Dudley, was born with CF. And she filed a wrongful birth lawsuit against her OBGYN because I guess she had gotten an amnio or CVS test, and it did not come back positive for cystic fibrosis. And it was such a cruel thing to read. But do you fear, is that why there's like such this like push within the OB/GYN world to like constantly be pushing for these genetic tests?
No, I think it's really much cruder than that. It's money. These tests make a lot of money. These embryos make a lot of money for both doctors and the companies. And that sounds very, very, very cynical, but that's really the truth of it. Because if they really wanted to improve care, they should be forced, like we talked about the abortion statistics, they should be forced to put every bit of this in a national registry that they pay for out of their profits for all the millions of dollars they're making off all the tests. And then we get a chance to have all that data so we can do a better job of taking care of our people. And we follow through all this data then and all this testing. Are they doing that? No, they're not. So, but they're making a lot of money off of it.
Well, I mean, I guess I shouldn't be surprised because, I mean, I deal with the abortion industry every day, and that's what it is. It's money as well. It's money and power. Yeah, it's hard to think of these doctors doing that, but we've heard about that for years, where doctors prescribe medicines that aren't really needed. Instead, just lose some weight or get exercising.
Doctors are afraid that they're not going to, do the right thing, quote unquote, and they will get sued if they don't offer. But if you've offered it and someone recuses themselves from it, then that should end it there. They've given you, they don't want to do it. Why do you keep going back over and over and over again and harassing them about something that they've made a decision upon as an informed adult to honor their autonomy? Says, well, ACOG's all about autonomy. We're all about autonomy, right? Patient autonomy. So let's stop that then. He's being very maternalistic or paternalistic to continue to hound you about this particular test they want to put.
Yeah, I mean, it was definitely eugenics. I mean, it was pressure. I was livid at a couple of the appointments after I left, and the treatment, the patronizing. I remember after I delivered Bear, the pro-life doctor that we went to see, he went to Mass and actually missed the delivery of my son. So the midwife delivered Bear, and all I remember is they had given me an Ambien the night before because they said, oh, you're not going to deliver, just go home and sleep. I'll never take Ambien ever again, because I don't remember, I barely remember anything about the delivery of Bear. But I remember them asking me, do you want us to put an IUD in? And like, this is like moments after I had delivered Bear. And I just remember looking at my husband, like, don't let them put anything in me. Don't let them put it. And it was every time there was a nurse shift change after we delivered Bear. And everybody knew that we had a child with CF because I had gotten the cord blood stem cell kit, so they had to collect the cord blood. I wanted an immediate, and what we've done with CF with all of our subject children is I order a DNA test at birth, so that 5 days afterwards, before symptoms present themselves, we knew that Gracie had CF because 5 days later, her DNA test came back. And so everybody there knew we had child CF. So every nurse shift change after I given birth to Bear, I got asked, are you sure you don't want an IUD? Are you sure you don't want an implant put in your arm? Are you sure you just don't want, it was like instant. And I didn't even trust myself because I was so doped up still on this Ambien. It was absolutely terrible. And I think that for me really showed the eugenics of the movement, folks who are they believe that they're well-intentioned, but it is what you said. It is a eugenics mindset that's out there, and it pervades our medical culture. I guess to wrap it up, what do you wish just two groups of people that pro-lifers in general knew and would speak better into when it comes to your world with perinatal hospice and helping women in high-risk pregnancies? And what do you wish that medical students and residents would know?
Well, I think that for the public in general, as you said, in the pro-life organizations, just to be aware of the perinatal hospice and be aware of, there is a lot of data. In fact, I was just going back through before this to look at stuff, and I found another 5 or 8 or 9 studies that have been done looking at perinatal hospice and neonatal hospice. So there's a lot of information out there talking about the very positive and how this, as it's been introduced, the number of women and the number of families taking up for their children now and advocating, say, I want this, has grown exponentially. Even in France, it's gone up by I forget how much. I was looking at the number and going, wow, it doubled in 4 or 5 years in France, which is just, this bastion of humanism. So it's when people see it, they want to do it. They understand within their hearts and souls, this is the right thing to do for their child. I think for medical students and residents, again, be aware of the literature, know the literature, and ask very nice questions of people. Why are we not doing this, or is this something we could consider doing? And the final thing for every medical student and every resident is you must be excellent. You must be excellent. You have to be better than those who are around you so that you are able to speak with authority and be able to do the things that we've talked about in the pro-life world. And also, if you're quote unquote, don't want to do something, offer something else. If you don't want to go, as I wouldn't go to Planned Parenthood and do their physical examinations, which is what it was when I was a medical student, but I did more clinics and took extra call. So I said, I won't do that, but I will help here. The things I can do, I will do, and I will do them excellently, and I'll work very hard. And that's very difficult for anyone to basically dismiss. They can't dismiss.
Yeah, that's exactly what we tell pro-life students in all fields is you have to work hard and you have to be the best and you have to be above reproach because, they are going to look at you differently and when things come up. But if they know you're a hard worker, if they know you're willing to find a solution or a workaround, you're not going to get kicked out of medical school. I think that's, for me, this conversation has been really insightful because we've been kicking around Students for Life. We used to have a full-time med Students for Life director and we lost the grant funding for it. And it's just like, you know what, I just need to do it and hire that person and God will take care of it because we've got to have, I'm so sick of hearing from students in undergrad, yes, I always wanted to be a doctor, but I'm afraid to be a doctor. I don't think I can do that now. I hear it all the time of folks that are just afraid about their conscience rights, that they'll be forced to participate or, in some way perform an abortion. And that's the absolute wrong thinking. And it's going to lead to a nation without pro-life doctors like you. And we need lots of you out there.
What the other side, that the heart of darkness wants. The culture of death wants that.
Yeah, absolutely.
People don't. Trust me, patients don't want that. They don't want a doctor who's going to kill them. Seriously. They do not want that. I will tell you that for sure. Or their baby. They don't want somebody to kill their baby. They really don't want that. So there's plenty of things out there for pro-life students and residents. There really is. There's a whole world out there. They just, like you said, they just got to believe that that's where God wants them and trust them. And then just like you said, just be the best that they can be and be above reproach.
That's right. So how can folks, if they have an adverse diagnosis, can folks get in touch with you or med students get in touch with you? Is there a website? Do you have a secretary to help you?
I'm psychologically impaired. I admit it. I'm old school. You just, do I have my email in there somewhere that you can send me stuff?
I do. So do you want folks just to email me and I'll email you?
Yeah, just send them to you and then send them through an email to me and then I'll be glad to. Yeah, and if I don't have the answer, I know enough people that can help with that, yeah.
Okay, perfect, yeah.
I don't even mind phone calls if it's really, like you said, somebody who's really got an issue and they just need to talk to somebody. As long as I know that's been screened, that I can trust where it's coming from, I'll be glad to call too and talk with people.
Yeah, I get calls. Sadly, I get calls a lot just because people know my story and my family's story. And so I get calls from pregnancy center directors like, hey, will you talk to this mom who just received a CF diagnosis? And so that's something that we definitely, and I'm very grateful that we get those calls. So, and folks, you all have, most of you have my email, because if you ever get any of our emails from Students for Life, you have it. It's just Kristan@studentsforlife.org. SFLA.org. You can always send an email or question, or if you have a family member going through crisis, refer them to the perinatalhospice.org, or you can shoot me an email and I can get you connected with Dr. Calhoun or a whole host of other physicians that we're connected with across the country who are just complete, courageous heroes in this field. So Dr. Calhoun, thank you so much for coming on. I think this might be my favorite podcast I've ever done, because you spoke so eloquently into such a difficult conversation, and you were like out there being a hero. So thank you.
Very good to me. It allowed me to be involved in this, and this is my passion, and this is what I want to. As long as the Lord gives me strength and the ability, I'll keep doing it. And anybody who wants to come along, feel free. It's exciting. It's never boring.
That's right. That's right. And we'll do our best at Students for Life. We're just going to get on it, relaunch our Med Students for Life full-time initiative so we can get you out to more campuses, because more students need to hear this from you. They don't want to hear it from me because I'm the crazy political activist, but they want to hear it from you. You've got the experience and the street cred to go along with it. Thank you all for tuning in today. Make sure, for all that's holy, you share this podcast. If you've never shared my podcast ever before, I'm not mad at you, but I will be upset if you do not share this podcast, because this is a message that needs to be spread far and wide in the pro-life movement. So make sure you share this podcast. You can go to YouTube, and all the podcasts are on my YouTube. I don't know how you share podcasts on iTunes, but I know there's a way to do it, and more tech-savvy people than me can figure it out. But share this episode with everybody you know in the pro-life movement, because we have to have the tools to be able to talk and to address these situations, these heartbreaking situations that so many of us have had personal experiences with. But thank you all for tuning in. I'll stop lecturing you. Bye, guys.